icter is present, and there was mild tenderness in the right upper quadrant. We got his basic labs. We said that total bilirubin was 4.7, direct of 2.8, AST 879 units, and ALT of 1367. INR mildly rise 1.6, and ultrasonography showing mildly enlarged liver, otherwise normal ultrasonography. The first thing which comes to our mind in the patient of a young patient, history of outside intake of food, having initially loose stools, fever, then followed by jaundice, and with the onset of jaundice, there is disappearance of the fever. The first thing which comes to our mind is viral hepatitis in a young boy, and this is the season for viral hepatitis. We see lots of patients with hepatitis A-related liver failures in our ICUs these days. So not next, we got is IgM-HAV and hepatitis E virus, HPSAG as a protocol, and IgM-HAV was positive. So we labeled him as acute viral hepatitis due to hepatitis A virus. For this patient, we tend to monitor them for INR and a liver function test at least once in 3 days or 48 hours if the patient has any symptoms of encephalopathy. The patient is an altered sensorium. He needs to be admitted definitely to the liver intensive care unit. We also tend to start them on NSL system infusion if the patient is admitted, or give some supplementary medications and supportive care for this patient with a normal advice for a normal diet and plenty of oral fluids. The basic reason for this hepatitis A has a little bit of atypical presentation. Most of these patients, though present with acute viral hepatitis or acute liver failure, they may have a protracted course. Some may have prolonged symptoms as well after the prodrome, and some, at least 5 to 10%, may also develop cholestasis, prolonged itching, and presence of pale colored stools in these individuals. So if you have a patient who presents later on after its initial symptoms, who has a fever, jaundice, then developing cholestasis later on, even then you may find that the patient has hepatitis A positive even later as well. Till 6 months you may have HIV IgM positive. Till that time we can label him as acute viral hepatitis related cholestasis. There is subtle difference between acute liver injury and acute liver failure. The patient has only elevation of liver enzymes and there is jaundice and coagulopathy, which is this. So therefore, this individual without any encephalopathy, we label them as acute liver injury. If supposing this guy had developed any altered sensorium, then we are labeled them as acute liver failure. The duration between jaundice, coagulopathy, and encephalopathy is variable. But up to 26 weeks, we consider it to be acute liver failure. But actually, some definitions also say about 4 weeks. So second thing, this is the commonest symptoms. This is a common virus and which is seen these days. Common symptoms include fatigue, nausea, mild fever, yellowness of eyes, that is jaundice, abdominal pain, and dark urine. Diagnosis based on the history and positive antibody tests. And LFT typically shows elevation in ALT more than AST. Treatment is conservative. For these individuals, strictly advised not to take any complementary and alternative medications which may increase the risk of liver injury. There are no dietary restrictions. Corticosteroids are not indicated for these individuals. Yes, hand washing and hygiene is important. Hydration is must. Monitor INR and look for encephalopathy in these individuals. So second case, this is also quite common scenario. We all get in our outpatient department. 38-year-old female who has history of PCOD. He is hypothyroid on treatment. There are no habits. Incidentally found to have liver enzyme elevation, routine evaluation. This was the LFT she presented with. Bilirubin was normal. ALT was 107, that is SGPT was 107. SGOT was 46. She got an ultrasound done in outside lab, which showed that there is an enlarged liver, which are grade 2 fatty liver, and mild evidence of PCOD as well. So this is a typical history which we see in our routine practice daily, where usually patients have been labeled as non-alcoholic fatty liver disease. I'm not sure why yeah. The diagnosis is non-alcoholic fatty liver disease. This is also labeled as MAFLD, metabolic dysfunction associated fatty liver disease. And the recent guidelines label it as metabolic dysfunction associated steatotic liver disease. So this patient, if you see, I did not mention about the BMI, but BMI is must for all these individuals. The BMI is more than 25 and the individual has fat in the liver, it should be labeled as MASLD. The sugar, this is all the criteria which is commonly used for us in our laboratory to diagnose the patient of metabolic dysfunction associated steatotic liver disease. Sugar should be done, the fasting should be more than 500 or HbA1c more than 5.7. Blood pressure or treatment for hypertension lipid lowering agents or plasma triglycerides more than 150, or HDL less than 40 for males or 150 for females, or lipid lowering treatment, we label them as fatty liver disease, or recently nomenclature has been changed to metabolic dysfunction associated steatotic liver disease. So, but do not ignore all these patients who have fatty liver. You may be getting many of the individuals who present with fatty liver on ultrasonography, because there is all the prevalence in India is as high as 35%, and these patients can progress into steatohepatitis, where there is inflammation. At least 20% can progress to steatohepatitis. They can also progress to cirrhosis, which is the leading cause of cirrhosis. NAFLD is now the leading cause of cirrhosis, and HCC, liver cancer, can occur even in the absence of cirrhosis as well. If there is cancer, cirrhosis definitely has 2% risk, but NASH as well as fatty liver can also progress and develop liver cancer. Although there are multiple things which can modify this, that is genetic susceptibility, diet, gut microbiota, and environmental stress, but do not ignore NAFLD. Transient elastography is fibroscan, which we can get it done for these individuals to evaluate for evaluation of the fibrosis. Third case, again, 39-year-old male, chronic alcohol consumption for 8 years, almost 80 grams per day, presents with jaundice, loss of appetite, abdominal pain, and pedal edema. On examination, you can see here several spiders over here. He has jaundice, pedal edema as well, tender hepatomegaly, spleen is palpable, clinically there is no ascites. Young individuals, we are noting that there is high incidence of alcoholic liver disease, and this is a classical patient who presents with significant alcohol consumption and having history of jaundice. So this is a case of alcoholic hepatitis. So the lab variables for this patient had bilirubin 11 of hemoglobin of 11.5, TLC of 12,500. Platelets are good enough because this is not a chronic disease, so the patient has good platelets. Bilirubin of 9.8 and direct bilirubin of 6.7. AST 198, ALT 87. Demonstrating enlarged liver 19 centimeters with spleen of 12.1 centimeters and mild perihepatic fluid. INR of 2.1. So this is a classical patient who has alcoholic hepatitis. Why do we see this? One is history of alcohol consumption. Second is acute onset of jaundice. Third, this is the criteria to define an alcoholic hepatitis. 40 grams of alcohol per day for females or 60 grams per day for males for at least 6 months. So 6 months is sufficient to develop alcoholic hepatitis. The last intake of alcohol less than 2 months. The patient has jaundice accompanied by fever, malaise, tender hepatomegaly, or any other decompensation, and has a bilirubin more than 3 milligrams, AST more than 50, and the ratio of AST to ALT of more than 1.42, and with the AST ALT not more than 400, it is definitely labeled as alcoholic hepatitis, which is the classical feature of this patient which we noted here. So any patient with alcoholic liver disease or alcohol use disorder, get an ultrasonography done, evaluate for get a fibroscan if possible, evaluate his liver function test, rule out other causes in the absence of any other history of alcohol intake, rule out for hepatitis B, hepatitis C, autoimmune markers in females especially, and ceruloplasmin in the younger individuals. Suspect advanced. If you suspect there is advanced fibrosis, get a complete liver function test, international INR, platelet and WBC counts, and endoscopy to look for varices. So common causes of acute hepatitis in our scenario includes infectious causes and non-infectious. Infectious includes hepatitis A, E, B, hepatitis C, dengue, CMV, hepatitis herpes simplex virus, and EBV virus. Dengue, one classical feature is there is usually AST more than ALT. Otherwise, all the viruses have ALT more than AST. Non-infectious, common is alcoholic hepatitis, non-alcoholic steatohepatitis, autoimmune hepatitis, drugs, Wilson's, and if a patient has gallstones and there is a passage of stones, it can also lead to acute hepatitis. So what to do when an individual presents with altered liver function test? Take a complete thorough history of outside food intake, drugs, alternative medications, concomitant autoimmune diseases, look for autoimmune hepatitis, history of alcohol consumptions, examine for signs of liver cell failure. Investigations, commonest one is liver function test, ultrasonography of the abdomen, INR, check the platelet count, and fibroscan if available. Key points to remember in all these individuals: ALT more than AST in thousands, then viral hepatitis is the commonest trigger. ALT more than AST in 100 to 10 to 100 is fatty liver disease. AST more than 8 in thousands, it might be either drugs or the patient may have ischemic hepatitis, shock, which is usually seen in septic shock, or rhabdomyolysis. We had a patient who had presented with the heat shock, because of the severe heat over here, he had presented with AST more than ALT elevation, he had rhabdomyolysis. AST more than 1800s, alcohol, autoimmune hepatitis, and drugs. These are the common trigger points. Thank you. Any questions? I'll be happy to take.
Okay, we'll have the questions at the end. Thank you very much, Dr. Anand. Then you have